evening, everyone. Thank you very much for joining us. My name's Andy Fletcher. I'm the Chief Executive of Together for Short Lives, and you're very welcome. Thank you very much for joining us. If I start to encroach towards the back of this and I look like I'm about to fall, please do say, shout loudly. Tonight, you're going to hear some fantastic speakers and panelists, and they'll introduce themselves in just a moment. But I just wanted to say a huge thanks very much for all of your ongoing support. You all know, I think, that children's palliative care makes an enormous, powerful difference to children and families in helping them make the most of every moment they have together. And you also know some of the significant challenges that families face and the sector faces at the moment. And we'll be touching in a minute, I think, you'll be hearing this evening about the growing numbers of children and their increasing complex need, which means that many children find themselves at home with their families caring for them 24 hours a day, 7 days a week. And that can be incredibly challenging and puts a lot of pressure on families. And Together for Short Lives is here to try and bring the services together and advocate for families so that each family can access the care and support they need when and where they need it. And with your support over the years, we've been able to reach more families than ever before through our family support. We've been able to advocate for policy change to help make the lives of children and families better. And importantly, with your support, we've been able to distribute more than £35 million to children's palliative care services that rely on voluntary donations. But we know there's lots to do, and we know there's big challenges facing the sector and children and families, in particular around funding and access to services, big shortfalls in terms of what's available on the ground, and putting increasing pressure, as I said, on family life. So I'm not going to cut across what's going to be said. I'm not going to use up more time, only to say a huge thanks for coming. I have also been told before I hand over to Rachel that just from a logistics point of view and a safety point of view, if there is no fire drill planned and if the alarm goes off, there are exits at the end of the building there, and you can see over there and to assemble at the front of the building. So thank you for coming. We'll wrap up at the end, but I'm really delighted that Dr. Rachel Clarke is able to chair this evening. I will leave you in her very capable hands.
Thank you very much, Andy. And these capable hands have already hurled the microphone off our very thin platform once, so I'll try not to do that again. Well, thank you. And I have to say it's a real honour to be here this evening, because I think that the work Together for Short Lives does is phenomenally important. I mean, one of the most vitally important charities in the UK. I'm an NHS palliative care doctor, and I'm also an author. I've written 4 books about medicine in the UK and palliative care in particular. And so I see firsthand the incredible, just miraculous effects that good quality palliative care can have, not only for patients, but also for their families. And these are effects that live long, long beyond the life of the patient with a life-limiting disease. It can be incalculable how precious simple, good quality palliative care can be for families who are bereaved, and perhaps never more so when the person who has died is a child. So it's incredibly important. And of course, the flip side of that is when I see the dreadful harm that can come from that care not being in place. And we'll touch on this evening. So just to explain the format of this discussion, we have got 3 absolutely phenomenal speakers. Their collected experience and expertise in this field, I think you will find riveting to hear. We're going to hear from them first. We're going to watch a couple of very short videos as well, but we will absolutely make sure that there is plenty of time at the end for you to ask all the questions you would like to. So save them up. We'll hear from our panel first and then open the floor up to you. And to begin with, I'm going to ask each of the panelists just to introduce themselves. Perhaps Francesca, starting with you.
Yes, testing. Hi, I'm Francesca. I'm a children's palliative care nurse and a fundraiser for Together for Short Lives.
And over to you, Lorna.
Good evening, everyone. I'm Lorna Fraser. I'm Professor of Palliative Care and Child Health at King's College London.
And Clare.
Good evening. My name is Clare Buchanan. I'm a mum of twin boys, Oliver and George. Oliver sadly passed away in December, just gone from a brain tumour. He was an extraordinary boy. I can't put into words what he was like and how much we missed him, but I will let him speak for himself.
Tonight I'm going to be doing a dancing show and performance. Enjoy the show. Peace.
Okay. So, can you tell me your name?
Superman.
Is that your real name?
No.
What's your real name?
Oliver.
I walked across an empty land. I knew the pathway like the back of my hand. I felt the earth beneath my feet. Sat by the river and it made
Kings always have this kind of meal every day.
The Kings like turkey meatballs,
Yes.
and you've got your sword next to your plate.
Yep.
Okay. Just in case of.
Dragons.
Okay.
I came across a fallen tree. I felt the branches of it.
Tell me about this.
He's called Oliver
Hmm.
and he says quack quack.
What is he?
He's a puppet.
Oh, simple thing, where have you gone? I'm getting old and I need something to rely on.
This says empty. If you take away the N and the Y, it says empty. If you take away the P, it says empty. And if you take away them, it's empty.
Oliver from Stockport was diagnosed with a brain tumour. His classmates immediately decided that they wanted to help in whatever way they could.
It's nice to know that my friends at school are supporting me.
Sun is out, plant growing, tea outside, sunshine, whenever, when we're playing outside. You're all asleep. George is Lex Luthor, and I'm Superman. You and Lex Luthor and me are going camping.
That sounds fun.
And after the camping day, it's gonna be Halloween day. And you're across classrooms.
And then what will happen?
It will be Christmas Day.
What day will it be after Christmas Day?
Dinosaur Day.
Oh. What do we do on Dinosaur Day?
We dig for big dinosaurs.
Why don't we go somewhere only we know?
Cheers! Ching! Cheers!
Cheers. Unbelievable. Cut.
Absolutely beautiful film. Thank you so much for sharing that, Clare. Would you be happy to share a little bit more of your family's story and importantly, what the palliative care that you received meant, and also how Together for Short Lives supported and helped you?
I certainly would. With the oncology journey, unlike children perhaps that have been diagnosed with something from infancy, there's always hope. There's always another treatment. There's always a new drug, something else to try. And that sort of palliative point comes when all that hope is dwindled. For us, this was September last year. Oliver had not long had very successful surgery to remove the tumour. It was amazingly successful, but within weeks it had grown back more aggressively and spread rapidly. I wanted him to die at home, and I was adamant that that's what was going to happen. Our Macmillan nurse was charged with putting a care package together, and I remember her coming to me saying, I don't think we can make this work at home. We have to get resources from the hospice and resources from your local NHS trust, and the hospice don't do this kind of care anymore, and your NHS trust are saying that they can't commit resources to this. And 9 out of 10 parents in that circumstance would just go, okay, their child will have to go to the hospice or stay in a hospital. I was not going to accept that, and said, I will beat down whatever doors I have to, but you're going to make this happen. And had to jump up and down a lot and shout at a lot of people and scream and beg and draw on the resources of friends who are kind of high up in healthcare in Greater Manchester. But lots of parents don't have access to friends who are high up in the NHS. And I'm lucky that I was actually able to get all those people round the table, and a care package was finally put together that enabled us to keep Oliver in his home environment. His end of life was as amazing as I could have ever made it. He was surrounded by friends and family. We talked about it being an old-fashioned death. It was the care of people who loved him, with pets and animals and candles and music. And I will always have that comfort that I did everything I could for him and made it as wonderful an experience, not just for me, not just for him, not just for his brother, but for everyone who was involved. And that significantly shapes my grief as we go forward as a family, knowing that it was as perfect as it could have been. We found Together for Short Lives sort of quite early on in that palliative process as we were looking for resources. I'm the kind of person that wants information. I want to know what's going to happen. When you are pregnant and you're having a baby, you read books, don't you? You find out what's going to happen to you. That also needs to happen if your child is dying. You need to know what is going to happen. Not everybody wants to face into that, but I did. I didn't want them to be fear or shock, or I didn't want to be faced with knee-jerk decisions that I would then come to regret. So I needed to plan it out. And that's how we found Together for Short Lives, because we discovered them through the online resources that you have had available for advanced care planning. The recommendation of books like Follow the Child, which was massively instrumental in how I approached Oliver's end of life. So that for me was a huge benefit and helped me to face that situation with knowledge, with information, with confidence.
Thank you. Thank you for sharing that. It's very hard to hear what you've just described, because essentially you've talked about at that point where you knew your little boy was going to die, you also found out you had a fight on your hands to achieve what you wished as a family, which was for him to die in the bosom of his family at home. And how on earth did you confront that? Because one of those things is hard enough, but to have to do both seems almost unimaginable.
It certainly gave me a focus for my anger, and it gave me something to do. And I made a nuisance of myself, which, you know, comes naturally. But I was not going to take no for an answer. And I would apply whatever pressure I could to do what I knew was going to be right for my child. It would have been nice had there been a care package that was off the shelf, that we could have just gone, yep, this will happen and this will happen and these nurses will come this day and this, but it was literally held together with blue tack, the plan, and it was 1 week at a time, not knowing if we would be able to continue the rota of nurses into the following week. And it was so dependent on goodwill of nurses that came in their own free time sometimes. And it should not be like that. It really shouldn't.
No. So an obvious question: how would you like things to be different, and what needs to be done to change the current situation, which is clearly not working as it should?
I think information is key. Understanding your rights, what you should be entitled to, how other people have experienced that journey, and knowing what you can and can't ask for or demand, but having the choice and the right to choose what you feel is appropriate for your child, your family. You know, not everybody would make the same choice I made. For lots of families, a hospice is the right environment for them. A home environment may be the wrong circumstance, but you should be able to make that choice.
So essentially, you would like services to be set up so that as a parent in that situation, you can choose your child's end of life care. And that's the choice that initially was essentially denied to you, wasn't it?
Yes. Yeah, absolutely. The difference it will have made long term to my family, to Oliver's twin brother, will be immense. I don't think we've come to realize yet just how significant the decisions we made at that time, and that we were, you know, the care we were able to realize. I don't think that will manifest for many years to come. It's crucial.
People often imagine, understandably, that the death of a child in whatever environment is going to be unremittingly dark and bleak and dreadful. But I'm imagining that once the care was in place for Oliver to be with you and the rest of his family at home, there were perhaps some beautiful moments. And would you be willing to share a little bit of what it was like with the care that you needed?
Absolutely. It was beautiful. I'm looking at my friend Rachel, who's part of our care as well. We had Oliver at my parents' home. They have a really beautiful big lounge with floor to ceiling windows. His bed was in the window looking out over the hills, looking up at the church where he now rests. And we had he used to love camping and campfires. And we found all
And
these candles and dinosaurs. Yeah, we didn't get any dinosaurs, but we had loads of candles everywhere that smelt of woodland and campfires and gingerbread and marshmallows. And we had those burning all the time. We had guinea pigs and dogs and I slept on a mattress next to him, but I couldn't be awake 24 hours a day. So we had a roster of friends that would come on 3-hourly shifts through the night, and they would sing to him and read to him and hold his hand, and knowing that he was being cared for by people who loved him, who had been part of his life's journey up to that point. I could sleep. He wasn't with strangers. It was an extension of my care, and we could talk around him and laugh, and we had fun. It was the nurses used to love coming because my mum would roll out it was December, so there'd be mince pies everywhere, and wine, 5 o'clock, all the wine had come out, and it's surreal, really. It was lovely. It was lovely. It was a very, very special time. Time stood still almost, didn't it? Yeah, it was.
And you had that haven because after the mother of all battles, and I use that word deliberately, you got the care that Oliver needed to enable you to have that.
Yep.
And it's interesting, isn't it? Because we hear an awful lot in the news about what we can't afford as a country. But if we can't afford that for children who are dying, we're losing our way, because what you've just described to me, it sounds like it's absolutely priceless.
It was priceless. And I can't believe, cost-wise, that would cost more than caring for a child in a hospice or a hospital environment.
Yeah.
I mean, they didn't even need to bring their own mince pies. We provided those for them. And our family and friends did the majority of the care. So I'm not sure that, the cost benefit analysis stacks up.
No. Thank you so much for sharing that incredible testimony. Moving on to you now, Francesca, or superwoman, terrifyingly energetic nurse extraordinaire. Could you tell us all a little bit about your background? So why did you choose to specialise in paediatric palliative care, caring for children with life-limiting conditions? And you're going to now also need to put us all to shame by telling us your fundraising exploits. You can tell by looking at her that they're fairly athletic.
So in terms of why I went into children's palliative care, I think it started before I became a nurse, when I read a book called Hannah's Gift. I don't know if you've heard of it. So it's about a little girl called Hannah, who was 3, and she had cancer and she sadly died. And her mum wrote this book called Hannah's Gift, A Life Fully Lived. And it spoke about the joy that Hannah bore and the importance of ensuring that she had that joy and that she lived her life. And for me, that stuck and that stayed with me, that children are children, and that I didn't go into palliative care to look after children that were dying. I went in to enable them to be children, to have those moments, and to be able to give that support that would mean that they could make the absolute best of their life that they had. So that's, and then I worked in the NHS for 10 years. I was always interested in palliative care, and I find this really interesting because it seemed like such a separate subject in the hospital. I worked in a top London hospital for 10 years. I never really knew what the palliative care team did. I didn't really understand it. And it was only when I left there and went and worked in a children's hospice, which again, the jobs come up separately because they're charities. So it wasn't an obvious in for me. I didn't really know that much about it. And then by chance, a job came up near where I lived, so I went for that. And then my eyes were just completely transformed into what a difference children's hospices make, and most importantly, what children and families go through and the support they need, and how it's people don't understand. I didn't understand as a nurse for 10 years what children and families go through and what they need. So if I didn't, how do we expect everyone else to? And how do we expect those people to be able to provide the support and be in that position? So then that's where I felt really strongly about being able to advocate for these children and families and being able to make the biggest difference I can. And I want to highlight as well that the idea for this challenge, and when I felt this, was before COVID. This was 5 years ago, and things have got worse since then. At that time, I thought these families don't get enough support. We need to be doing more. And things have only got harder since then. Should I move on to the challenge?
Tell us what you did, but also there's for Henry on your arm.
Yes.
What's that?
So Henry, can I say about the challenge first? Just because so the challenge, so I went to a talk by Ben Fogle, an adventurer, about climbing Everest. And at the end, he said, find your Everest. And I love that idea. I love that concept. Like, you didn't have to climb Everest for that to be your lifetime achievement. Like, you could think of your own and what it could be. So I thought, what could I do that involves children's hospices and brings people together and advocates for our children and families? So I thought, I know I could cycle around all the children's hospices. And big credit to Together for Short Lives here, because when I approached them with the idea, I didn't have a bike and I couldn't really cycle. And I couldn't think of a greater reason or cause. So I came up with this idea. I called it Chat UK, children's hospices across the UK. I like the idea of it being chat and getting people talking. And so the idea was, I can show you the map on my back later, but it was to cycle around all the children's hospices over 10 weeks. I did it over 10 weeks. It was a very complicated dot to dot. They're all over the place. And then Henry, a month after I had the idea for Chat UK, my best friend's son Henry was diagnosed with acute myeloid leukemia. And so he was 6 at the time, and then he relapsed. He then had a bone marrow transplant, which was all during COVID. So when he was first diagnosed, I was able to go into the hospital and support and give that support then. And then with the second time, it was just so hard not being able to provide any of that, and having all of that support. You knew being in the hospital felt like a different world, like a day felt like a lifetime, and not being able to be there helping was really hard. And then after the bone marrow transplant, he relapsed again. And then, really tragically, he died 4 months before I started Chat UK. So in February, I've got a photo, actually. That's Henry. I think it's nice to see a photo. And then with Henry, he had acute myeloid leukemia, which, a bit like you were saying, Claire, the focus with cancers is very much hope, hope, hope. And that was the same with Henry. And I obviously, with my experience, I've got this photo as well. Oh, no, not that one. That's a different one. This one of us, which is in December. So that's 3 months before he died. And we had no idea at that point that we were hoping he would get to Manchester for a trial. But that photo is really important to me, because at that point, I was so desperate for him to live. Like, I couldn't think of an alternative. I just hoped and hoped he would live. But I was also desperate for palliative care to be involved, because I wanted to know that if he did die, if that was out of our control, he got the best care possible. And palliative care weren't referred until he wasn't referred to palliative care till the Friday before he died. So and he was in hospital. So he didn't even get the option of choice. I don't know if we went back, what a different pathway would have been, but choice wasn't even an option, because palliative care wasn't brought into his story until much later. And I'd referred him to Demel's, the Children's Hospice, when he relapsed the first time. And I'd hoped that would be an in, but children's hospices work in lots of different ways. And Helen House, where I'd worked, was very medical and had lots of doctors. So I assumed that Demel's was the same, and I didn't realise it wasn't, and that actually they need referral to the palliative care team alongside them. So that referral came late. So I feel like I've seen many different sides of children's palliative care, and I feel like Claire, like I have a very strong view on what the gold standard is, and being able to ensure children and families get that and get that choice and care.
It's very interesting that both of you have talked very powerfully about choice and the ways in which parents and families and children can unintentionally be denied the choice that, of course, should be theirs. All the different options of care should be available, and it should be children and their families deciding on those, shouldn't it?
Yeah.
For you, as someone with a wealth of experience as a children's palliative care nurse, what do you think the main barriers are at the moment for children in need of this kind of care? And how would you like to see things differently?
Okay, I've got a few. So I think funding is one. Children's hospices offer, incredibly valuable supportive resources, and a lot of them enable the choice that, as Claire was saying, and as I was saying, that children, and families need to have that choice. So funding, they're all charities, so they have to raise millions each year. That's not necessarily a sustainable way of funding. So that's one of them. The workforce is a huge one. So when I cycled around all the children's hospices, I asked everyone what their biggest challenge was, and the majority said staffing, and in particular nurses. So we know that we're facing nationally a nurses shortage, and children's hospices in particular are very impacted. And, I'm seeing it even as I work now on a day-to-day basis. Children's hospices, they're having to work out if they've got the staffing to be able to offer a service. And, we shouldn't be in that position. We should have the staffing to be able to do that, so that, because it's not a true choice otherwise. We're not giving families choice unless we've got the resources to be able to do that. And then and perceptions are a huge thing as well, I think. So children's palliative care, a lot of people naturally are very scared of it and scared to talk about it. And you see this from a societal perspective, you see it from a professional perspective. So sometimes, like in Henry's case, the conversations aren't brought in till too late. And it's really important that those can come from the professionals. And that was the outcome, like speaking to his consultant afterwards, was that palliative care should have been brought in earlier. And many of the children under the hospices would say, we wish we'd come 6 months earlier, or we wish we'd come when it had first been suggested, but we were too scared, and then we didn't. We waited and waited and waited. And you want families to have that support at the very time that they need it. So those are a few of the things.
Just the tip of the iceberg.
Yeah.
So I hope I'm not putting you on the spot asking this, but you've just touched on something that could be corrected without a big injection of funds. So some of the perceptions and the sort of anxiety about involving palliative care. So suppose there was a child like Henry where you're keeping on with the chemo, you're trying, maybe there's a trial, he's getting sicker, and perhaps the oncologists are reluctant to mention palliative care to a family because they're scared that that might be perceived as taking away all hope. How do you broach that in your conversations with children and or their parents? So when you meet them, they may be very, very scared of you because they're slightly seeing you as the kind of angel of death. Are you the person who's going to take the hope away? How do you deal with that?
So where I work at the moment, I'm a children's community nurse, and generally all the children that have a cancer diagnosis, we ensure get referred to the local children's hospice. And that's, those with acute leukemia, ALL, where you have a very good prognosis and you wouldn't expect anything other than a cure, other than for a very few. And we normally approach it by explaining what a hospice is, and starting with all the things it can offer, which at that point in time, the support it can offer is often like support for the siblings, support for the family, I always think with the children's hospice, like if someone said to you, do you want some extra love and support and care and expertise? Would you say no? But the word hospice suddenly puts a barrier between that. So that's how we do it in terms of children's hospices. Palliative, I think, is a much harder area. Like when I did my challenge, I thought, we just need to change the perception. Like we just need to change what people think of the term for children, because with adults, people's experience is palliative very much end of life. And I didn't know for children, you can have children where the hope is cure and you discharge a child from a children's hospice. I wouldn't have known that. So I thought, we can change the perception. I think it's a big thing, because for me, for me, how I've got around it, I think, in my job in the past is by being me, if that makes sense. Like when you meet them, when you meet families, breaking down those barriers by showing that you care and showing that you care about their child and you want what is best for their child. And I think that is the bit that changes perception, when you can build up that relationship and show what you can actually do. I think the word is still, really, and you have to have that opportunity to do that.
Now I know a little bit about some of the goings on in children's hospices, but perhaps you can share just a flavour of your work and why going to work in a hospice, in a children's hospice in particular, is not walking into a bleak, dark place. Can you give a little flavour of what it's like?
Full of, the ones I've worked in, full of life and love and fun. I mean, it's designed for children, so it is full of all the things that you would want your children to be doing. There's activities, there's tend to be jacuzzis or like some sort of swimming pool. A lot of the ones I went around actually had cinemas, like they'd had to get together for cinema, and I thought, how cool is that? If you are a young person or a child, you could be potentially very sick, you're not able to get the opportunity to do things that other children necessarily can. A children's hospice is about enabling. It's about enabling children to be able to have those opportunities, because when you have either a complex condition or you're very seriously ill or dying, those things are so much harder to achieve. All of the things that you want to do are so much harder. The logistics of transport anywhere or travel and managing symptoms whilst you're out or wherever you are, you want to feel safe, you need to feel secure, and like you've got all the right plans in place. And that's what a children's hospice can do. So it can, and that's what I love about my role, is you get to be someone with knowledge and support that can help with all of the clinical side of things, but you also get to bring the joy and the fun as well, which is actually, this is one of my photos of me caring for a dying child, who was a little girl called Neve. And we had a pajama party. Her and her sister stuck googly eyes all over my head and with a party hat. And that was, and I forgot I was wearing them. And then I was in the car home and needed to get petrol, and they're still in my car now. So yeah, and it's like Claire was saying about people being there to sing songs and read. You know, a child is a child and they're still that person and who they are right up until the very last moment. And we need to be able to see that and enable those opportunities at any moment that we can. And we need to ensure families have the support. And I think this is another important part of the hospice, that families have the support so that that can be their focus as well, because there are so many other things you have to think about when you're caring for a sick child, as well as alongside family, as well as directly caring for your child and the medications and all of the things that need doing, that it's really important. And I think it's also really important that we and all of us that can advocate are doing that, because someone looking after a sick child should not be having to do that. Like, we, particularly if we've got experience in that area, it's not, we haven't, these families, you know, hope will only ever go through that once. We need to be the ones with our experience advocating for all these things that can make a difference. And that's what Together for Short Lives does. And, you know, that's what I think it's really important we do. And using experience, like, it's incredible that you're here, Claire, to be able to, you know, give your story to show how important that is.
Brilliant. Thank you very much indeed for sharing that. Lorna, you are a professor of paediatric palliative care. I know you have a special research interest in the epidemiology of life-limiting complex childhood conditions, don't you? So you probably know more academically about this field than anyone else really in the UK. Could you talk a little bit about what your research has revealed about the prevalence, the frequency of life-limiting conditions in children, perhaps how that's changing, and a bit about what the complexity of caring for children with these conditions is, and how do we support people, parents especially, in that situation?
Yeah, thanks, Rachel. I guess the first thing I'd like to say is It's 40 years since Helen House opened. It's more than 30 years since we had the first consultant in paediatric palliative medicine a few miles along there in the big shiny Great Ormond Street. And yet we still have a health and care system that sees paediatric palliative care as an optional extra. You know, we need to do better. And this isn't all about funding, but we do need to do better. So we do have some data, but I also speak to parents, and I've got something fabulous qualitative work I'd like to share as well, if that's okay, Rachel. So there are more children living with complex and life-limiting conditions. And part of that's a good news story in that we can keep children alive longer using medical technologies, caring for them well. But it also means that they have very high care needs, and often those care needs need to be met by parents and other family members. And we have huge expectations for parents, and yet so our acute medicine, medical care, our acute surgical care has advanced hugely, but our health and care system has not. We have not developed the necessary support in the community and at home to support parents to be what's most important to the parents that we've interviewed is to be a parent. And it's very, very difficult to be a parent if you're also being an administrator, if you're also trying to coordinate your child's care, if you're fighting for the care that you require.
And worrying about whether or not you're going to get it. You know.
Absolutely. 70%, we've talked a lot about hospices, 70% of children who die in a hospital setting. That has not changed in the last 20 years in the UK. We still have tertiary children's hospitals in England and in other parts of the UK that do not have a paediatric palliative care team. Of the hospitals that do have these teams, only a third of them meet the multidisciplinary nature that the NICE guidelines, our national clinical guidelines, recommend. And more than 70% of those teams are relying on charity funding for at least one of these posts.
And what proportion of families would like their child to die at home or in a hospice rather than a hospital setting?
I think that's really variable, and the evidence is mixed, and I think it also changes for families because it very much depends on the time and the place and where they feel safe, where they trust the staff. And for me, it comes back to choice. This isn't necessarily about more families having their child die at home or in hospice. It's about supporting families to have a genuine choice, and that means we have to have services available everywhere in a timely and responsive manner. And that's what we really struggle with at the moment.
So, I mean, statistically, you couldn't really have painted a bleaker picture. That's not a patchwork quilt. That's a quilt that's been eviscerated by moths, and it's threadbare, isn't it? There's hardly anything there. So I suppose the obvious question is, how do we address that? So everyone in this room cares about that situation. We want things to be better. You're studying this. You've seen this state of affairs literally for decades, and it's not just children being treated as second-class citizens, it's dying children being treated as second-class citizens. How do we address that?
I think we need evidence. And, you know, not just because I need a job, but, you know, we need that's what policymakers and commissioners and people with money need evidence in order to, you know, in order to make changes. What we must do is stop describing problems. We've just published a paper which reviewed the barriers and facilitators to referral to children's palliative care. Nearly 200 papers about what professionals thought about this. We need to start moving on and actually making changes, and importantly, evaluating changes, because we still have I came into this field about 15 years ago, and one of the reasons was we had no evidence on which to base care for the sickest and most vulnerable population of children in our country. And we have a bit more evidence now, but there's still many, many holes in what we understand and how to care best for children and families. And we've talked about the role, you missed the donkeys, that's my favourite bit about hospice. We talked about the enjoyable things that hospices can provide, but we also have to recognise the really complex symptom management that can need to, and medical input that's required for children and families. And we have little evidence on that at the moment. I think we also need to think about how we use data. And, you know, I think the last time we looked, it was around 86,000 children live with a life-limiting condition in the UK, in England, sorry. There's more than 12 million children. That doesn't sound a lot, but it's 7 out of 10 PICU beds are care for children with life-limiting conditions. That's our most resource-intensive.
7 out of 10.
7 out of 10.
That's an extraordinary statistic.
2 out of 10 hospital beds, 7 out of 10 ICU beds. So don't tell me this is not, even for any reason, that these children are not important. They're important for many other reasons. But in terms of our health and care system, they're exceptionally important.
And you touched on the qualitative research that you've conducted with parents. Tell us a bit more about that.
I think I'm always exceptionally humbled at how parents will be involved both in qualities and being interviewed, but also participating in all of our research studies, and what they are willing to give. I'm always very humbled by. I think we've just finished a national study looking at end-of-life care for children, and we interviewed, I think, 45, 46 bereaved parents. And we had some fantastic examples of really good experience and some really good deaths like you have described, Clare. But we also had some examples of where things could have gone so much better and could have been prevented. And what I should have said in terms of the numbers is there's a higher than expected number of families living in areas of high deprivation coming from our minoritized ethnic groups, affecting more than one child in the family. And those are the families I really, really worry about, because they don't have the resources in the broadest sense of that word to know what they're even entitled to, far less to be able to fight for it. And why should they have to fight? And we've done a number of studies trying to get parents to look at their own health and well-being, and that's quite difficult because they won't talk about their child. And actually, I expected to see an increase in psychological distress and mental health issues. We also saw an increase in physical health issues, because parents don't have the time to be looking after themselves, because they are being parents and healthcare providers 24/7. And for many parents, this goes on for many, many years.
Does that resonate with you, Clare?
Yes, that really does resonate. Because you are a parent, a chemist, a pharmacist, a administrator, a taxi driver. You are all things to that child, and yeah, it's never ending, and the opportunity to just parent, I think, would be a gift that you don't get.
And who's looking after you as well?
Yeah,
I think that's
I certainly thought when Oliver was first diagnosed, again, I was jumping up and down, making a pain of myself. I thought there would be a emotional well-being, mental health stream of activity or support that sat alongside the medical support. There is nothing, and that was such a shock, because having that well-being support would help eliminate so many visits to A&E, so many. It would help coach the parents through the journey, coach the siblings through the journey, explain things. But there is you just get tiptoed around all the time, and nobody sort of sets your expectations about what can and should happen. I was like, we all need psychotherapy. And nobody sat me down and went, what actually do you want to achieve through that? Because that's not actually going to make anything go away. Again, you don't know what it is that you're asking for. You just think there should be something there that isn't.
Did you at times feel as though one of the things that would really help you, and this again is perhaps something that's not expensive to provide, was some straight talking, some frankness, some candor?
Yes. Oh, yes. Very much so. I say yes, but I think sometimes when you you ignore the straight talking bits when you're being having a very complicated, horrific diagnosis explained to you. Your subconscious just glosses over some of the worst aspects of that, and all you hear is, you know, treatment, cure, going to try this, going to try that. So there's a little bit of resistance on your part, but equally there was a lot of pussyfooting around what was going to happen, and that's before we even get to the kind of facilities for talking to parents in hospitals, which just don't exist. The number of times I've been given terrible news in a corridor because I refused to go into the lavender room, because like nobody goes into the lavender room and comes out, you know, happy. So I stopped everyone. Like, don't take.
It was just room
don't take me
101.
in there. Yeah. There's just so many opportunities to kind of make it a bit better.
And incremental bits better matter a
They
lot.
do. They
don't
matter hugely.
Every little increment. Yeah.
They really do.
Andy, reflecting on what you've just heard, if we have any microphone that works,
I think we have this one now.
what do you make of what you've heard?
I mean, it's been incredibly powerful. All three of you spoke really eloquently, I think, about the experience of families, but also what it's like to support and care for children and families, and what the system looks like. So a lot of it is sadly very familiar. I think, you know, we know that, as Lorna says, the numbers of children are growing, but also the medical complexity of them is much higher. So families are having to provide the sort of clinical medical care often at home, particularly if your child has a long-term degenerative condition over many months and years. You know, you're not just looking after your child as their parent, but you're also doing all of those clinical, often really complex things that we wouldn't have imagined 20 years ago that parents are doing. And that can be very isolating. It can be very stressful. It can be a 24-hour-a-day, 7-day-a-week job. And Claire's already talked to that. You know, that relentlessness of support that means, you know, sleep can be difficult, exhaustion, and then obviously, as Lorna says, the physical and psychological impacts that has on parents. You know, there is no doubt the system, you know, Together for Short Lives, we work directly closely with families, supporting families directly, and Claire's talked to that experience, and we work with professionals to try and make the quality of palliative care better and share where it does work, and also educate and try and support non-specialists to kind of understand children's palliative care and not be afraid of it. And then we also work to change the system, and that advocacy bit is so key, because, you know, the system doesn't work for children, young people with these conditions. It, as Lorna said, you know, we've created a system that is very good at you know, emergency medicine and supporting children to live longer, and that is wonderful. But if families don't have quality of life with their children, then that is worthless. And actually, we've got a system that the health and care system at the moment doesn't work for children and families. And Claire's experience of that 24/7 care at home, we did some work. My colleague James and the policy team at Together for Short Lives mapping what's available to families on the ground against the NICE standards that Lorna talked about, and we found that, you know, there's a standard there that all families of a child with a life-limiting illness should have 24/7 care and support if they want to be at home at the end of their child's life, which seems, you know, a very reasonable choice. And we found
not really
that
the highest of bars, is it?
it's not really, is it?
For a rich country
In 2024, in one of the most civilized, allegedly, parts of the world. But what we found was in you know, more than 2/3 of areas that isn't available, and therefore families do have to fight and battle at the time when they have the least energy to do it. I'm an optimist, so I kind of look at the third and think, you know, what are they doing to make it work? And so I really fundamentally believe that if we know that high quality palliative care, particularly towards an end of a child's life where families do have that choice to have that support where they want to be in hospital, hospice or at home, we know that that has a profound positive impact. And we've used the word positive and joy, and it seems kind of counterintuitive to use those words, but parents often use those words about the child's end of life where they get that support to have that experience in the way that they want it, so that when their child dies, they feel that they've done everything they can to make that as special as it can be. And I think if a third of areas roughly are offering that, then the other 2/3 shouldn't be far behind. And, you know, that's what we're here to do, is to try and advocate to try and make that happen on the ground. So families' experience is the same whether you live in, you know, Cornwall or Kirklees, really.
I very much like that attitude. It exists in parts of the UK. So how do we make it exist across the UK?
And Lorna's point is right. You know, we've got to get away from, we all know what the problems are, and countless administrations of all colours and persuasions. We've made incremental progress with funding and availability and access and quality. But the reality is that the pace of that change is just too slow. We estimate, again, the team have mapped, if you took those standards and said, okay, if those are available in every part of the country, what would you need? So the things that Lorna talked about, specialist medical team in a tertiary hospital, community services that Francesca talked about, community children's nurses, children's hospices, support at home, support in the community. What would it take financially? And we reckon there's a gap of about £295 million, which at one level, you know, that's a big number. And on another level, it's a tiny number when you think about it in the context of NHS spending. And our job is to make the case for, not only is this the right thing to do, because these are some of the, you know, if we can't get support and care for dying children right, then we're not doing much right. But also, more importantly, if we get it right, then we can save the NHS huge sums of money, both in the short, medium and long term. Care and support at home in the community is, as you say, significantly better cost-wise. But then obviously if we can address some of the things that Lorna talked about psychological and physical health, then we'll save the NHS significant money in the long term. And it's this long view that we need to start, of all governments, of all persuasions, to start getting a grip of. And that's the bit at the moment. It's very difficult because every day there's another family living this experience and then, you know, not getting the support they need.
Thank you very much. We're going to watch another short film now and then open to the floor.
Noah's a happy child. He's full of smiles, always sort of lights up the room when he's there. He's got real complex needs. He's blind, he's deaf, he's got complex quadriplegic cerebral palsy, global developmental delay, epilepsy. He's non-verbal. He's fed through a gastric peg in his stomach, and he also has a life-limiting condition, which means ultimately that you know, he won't live a fulfilled life as most young kids do. When you first get told, and in the cold light of day at the start, it was shock. Probably for the first time in my life, I didn't have an answer or could see a way out or direction of what to do. But quickly you sort of realise, actually, as a parent, this is now your job to step in here and do the best you can. We get 12 nights a year respite for Noah, which allows myself and my wife to have a bit of time to ourselves, because, you know, Noah needs 24-hour care and it can be pretty relentless at times. It isn't just around the physical day-to-day giving you respite. It's a lot more than that. What they also do as well is offer support to siblings. They've helped us write Noah's end-of-life care plan. Probably not something that, you know, people like to talk about, but the reality of it is that's the situation that we're in. Without Acorns, we wouldn't have any time to have time for ourselves. I think it'd be very difficult for us to do things with the girls as well, so it's really important that we have that support from Acorns that just allows us to have those moments.
Tilly has Rett syndrome. which is a neurological condition, which basically means that everything we take for granted and how we move, Tilly's messages aren't getting to parts of her body, so she can't do anything for herself. Intellectually, she's aware like any other child her age, but physically, she can't use her hands or move her limbs or transition or do anything without help. And it's a progressive condition in terms of it isn't stable. I was due to go back to work and I just thought, I don't really know how I'm supposed to go back to work and function as well as cope with having a seriously ill child and trying to keep her well. I emailed Together for Short Lives and your family support manager messaged me and said, you know, we can help. She was just amazing really, because everything I was saying, she would come back to me with suggestions and challenges and challenge my way of thinking and reframing things. And I respected it because it was from an organisation that works every single day with children with serious illness or life-limiting conditions.
I look out onto the Clare House playground from my office, so I can see every day the difference that we're making, particularly during the summer. To see the enthusiasm, the dedication, the skills, the experience of our staff on show and how they're able to make every child's stay memorable, help them to achieve things they would never otherwise be able to achieve, to help them in times of joy, but also to support families in times of great grief. I think it's an extraordinary thing to be able to experience firsthand. Without Together Short Lives, we cannot speak as a sector, we cannot speak as a movement. And so we're all then lone organisations doing the very best we can. I don't think any of us want to see the postcode lottery that families face. Just because a family happens to live really close to Clare House on Merseyside should not mean that they get a better or worse service than another children's hospice in another location. That difference that Together Short Lives makes shouldn't be underestimated. The first children's hospice was only opened in 1982, Clare House opened in 1998. We're still developing the experience and the knowledge base that we need to be able to demonstrate to society the difference and the impact that is made by the work of children's hospices and the wider children's palliative care provision. And so supporters have got that opportunity to come in at the very start of that journey and change the world.
I see Together for Short Lives as very much being part of the coordinator and signposter, I think, for professionals. Children are living a lot longer now, many of them with a life-limiting diagnosis, and that's brilliant. But we've got to therefore meet the requirements of those children and families. We can signpost professionals to resources, to what's available, and also most importantly we can advocate, we can influence. We've got that political network. You know, uniting the sector is about making sure that all healthcare professionals and social care professionals, anyone really who has an input and works with children and families, really understand what the needs of those children and families are and their role within that. High quality care delivered in the right place at the right time by the right team of professionals is really important. That meets the holistic needs of children and families and really what they want.
What a fantastic film. Brilliant. Right. It's over to you guys. You can ask any of our panel anything within reason. So please, who would like to ask a question?
I think so. Yeah, I mean, we met the new minister Stephen Kinnock a couple of weeks ago, and obviously they're in sort of listening mode, I'd say. I think and Lorna and I were having this conversation about where children fit in the sort of pecking order of support and priorities. I kind of feel that they're definitely open to a conversation, and certainly in opposition when making the right noises. In government, it's a very different beast, and they've got some significant big priorities. But I think for us, we're pushing very hard on the short-term fixes that we've talked about this evening around funding in the short term, but then there's a sort of longer term workforce plan and those sorts of bigger NHS pieces, of which children's palliative care is a smaller part, but it's absolutely fundamental that we get that right. So I mean, I'm an optimist, as I said earlier on. I think the noises are good, but we live in really constrained times. That's why I think for us, we need to amplify the voices that you've heard today, and hopefully you all play a part in this. There's work that you can do to support Together for Short Lives in generating really much needed funds, of course, and sharing with your own networks around the messages that you've heard today and the importance of care and support and the work we do. But really as well, you can help us advocate. We are a relatively small organisation that mobilises the children's palliative care community, and that involves parents and professionals, but also members of the general public with an interest in this. So the more we can do to bring those voices to the fore, the more government is likely to listen. But I'm optimistic noises at the moment, but I don't know whether you've got anything to add to that.
Yeah, I would agree. Certainly from the Health Secretary, I think children in general are going to be much higher up their priority list, which is fantastic. I would also say I think we had 3 or 4 lines in the Darcy report about the importance of children with life-limiting conditions. That's a lot compared to the whole report. So I'm hoping that has will be taken forward in the action plan that's going to come from that.
Very encouraging. Other questions?
Thank you. I think it's not always like it looks on the telly, I keep asking my counsellors, am I doing this right? Am I grieving right? It doesn't feel right. I'm not lying in bed all day, not showering, thrashing on the floor in grief. I'm functioning. I have another child. We have to get up and do stuff, and we have to live our lives. It's a new normal, but it has to be a version of normal. One of the slightly annoying things that people say is, God, you're amazing. I couldn't do what you've done.
Like you had a choice.
Like you have a choice. Like you have a choice. And I think grief comes in all sorts of shapes and sizes. And when Oliver was diagnosed, to get through treatment, you just have to grit your teeth and get on with it. There is no time to wallow. There is no time. There is so much to do, so much to focus on. You just have to get on with it. You have no choice. No choice. But it also feels very surreal. I'm not sure it's fully hit me yet, to be honest.
And it's presumably a form of trauma where now you're not allowed to fall to pieces, are you? You have George, and
I've had to go. Have to go back to work. I'm a sole parent. I have to earn a living. We have to keep the roof over our heads. And some days I'm busy with work. I'm busy with stuff, and Oliver's not at the forefront of my mind. And then there's the guilt that comes, at night of, God, I've not thought about him enough today. But again, that's where you need support. that continues after your child has died, to help you come to terms with it, to be a benchmark, and for people to reassure you that, you know, everybody's journey is different, and you're doing it right for you. And it might be different for somebody else. So, but that support doesn't, you know, it's not there other than what's provided by charities.
Thank you for everything you are doing for the sake of other parents now and in the future, because it's very obvious what motivates you, and it is an incredibly wonderful thing that you are doing to try and fight on behalf of other families. So heartfelt thanks for doing that. Yeah. We are rapidly running out of time, so I'm going to put everybody on the spot now and ask you. So Lorna, you mentioned something very important, that look, we can go through the barriers matter, but we also need solutions. We need to say, look, that this is how we want it to be. So each of you, if there was one bit of this is how it should be that you would like to see in place, what would it be? And I'll start. So I would like, as someone who works in palliative care, I would like medical training and nursing training now, and it doesn't cost money, it just needs to be organised. I would like the new professionals who are coming through to be trained in thinking about, recognising and talking about dying, because dying is a lived human experience and it should be taught as part of healthcare. So that's my one. Who wants to go next?
I think we should have standardised support for parents, as Claire described earlier.
Yeah, perfect. What about you, Andy?
If I'm going one thing, I won't repeat, but I think it sort of linked to both of those points. I think the way we organise this stuff needs to be a national solution to it. I think at the moment it's left, the way in which NHS is organised and health spending is organised and commissioning and design is very local. And that works great when you've got a big population of people that you can plan and consistently know you're going to need X number of hip replacements in a year and they're going to cost Y. So, well, this is how much we need to allocate and design the service. Children's palliative care is not like that. Yeah. The children are not big enough in number in local areas for this to work. So you've got complex children that require really complex packages of care and support. It doesn't work. And therefore you end up with this postcode lottery of it works here and it doesn't work there. And it relies then on goodwill. We heard earlier on about goodwill from Clare. I think also Lorna touched on it as well about, actually this is not just an issue in the voluntary sector. This is in hospital, in big teaching hospitals in London. Services are being delivered by qualified doctors and nurses who are funded by the voluntary sector. That is not an adequate solution. And it's not about necessarily more money, although we do need more money. It's about organising it in a bigger way that says, this is the pot of resources to make sure those standards are met on the ground locally. And it doesn't matter where you live. This is the expectation around choice that you will have, because this local patchwork, those of us who've been in the sector a long time, it doesn't work.
The last word, Claire.
Yeah, I mean, I would like to see a system that is capable of flexing itself around the child and not expecting the child to fit the system. So in the words of the masterpiece book by Sasha, follow the child. That's all anybody needs to do.
Thank you. Thank you so much. All our panelists, I'm sure you will agree, have been absolutely superb and generous in sharing your experiences, your expertise in making this discussion incredibly powerful and unforgettable. Actually, I will not forget this evening. So thank you all very, very much indeed. And I'm going to now hand over to Andy to wrap up.
Firstly, I'd like to say thank you to you, Rachel, for giving your time for it, and generously and sharing it so beautifully. I think it's not an easy thing to do, and you've done it brilliantly. I'd also like to thank the speakers for giving their time and and as you say, generously sharing their stories and experiences. I'm not going to dwell because we're nearly at 8 and you need to get a train, otherwise you're going to get in serious trouble. I would just like to say thank you for coming. Together for Short Lives relies really heavily on the support of people like you in the room to make this change happen. And as I said, it happens not because we make it happen, but because we hopefully galvanise a community of people to advocate for children and families and make a difference. And you can make a difference in lots of different ways. You can make a difference with your support networks, sharing our information that you've heard this evening, sharing these stories. You can help with bringing your own expertise and knowledge that you build in your own walks of life into the organisation. You can, advocate and campaign and lobby by joining our work with government. And you can also, of course, continue to help us financially with making this work happen, because it doesn't happen by accident. It happens because of the wonderful people in this room. So thank you for your support, partners, supporters, staff who've made this evening happen, but mainly to our great panel for all sharing their experience. So thank you very much. I think, is there some wine left, James? Lucy? So please do feel free to stick around. Equally, if you've got to run for a train, equally do. Thank you for coming. Hopefully catch up with some of you in the margins of a glass of wine. But thank you all. Thank you.